Okay, so I'm going to show you NG insertion, and hopefully this will go smooth enough that we don't have to start all over. So some of the things when we think about a nasogastric tube is why we're putting it down. Some of the reasons, of course, is that we could use it for gavage, lavage to actually flush out toxins. We could use it as feeding for nutritional support. And then we could also use it for suctioning, that maybe the GI tract is blocked somewhere and that we need to pull off those contents. So depending on what the use is for really helps drive what type of tube we're looking for. Now for the check off here, the one that we're going to be utilizing is what's called a Salem sump tube. Normally for an adult, this is 14 to 16 French, but this happens to be a 10 French. It can still get the purpose across. What's different about a Salem sump tube is it has this area that able to vent, so that if we need to pull things out, that this is a way that we can get air in the system, or actually it's within the system that sucks off, but it doesn't allow air to go into the stomach. This open area, what it needs on here is what's called an anti-reflux valve, and we have those sometimes in the hospital. They already have the anti-reflux valve included. And so we've got the blue part and then the white part. On the white part, you probably can't see here, but it's got little holes and that provides a venting. And so we are going to be placing that on there, okay? So we'll get to more on the Salem sump tube. This is considered a clean procedure, right? So some of the other supplies, when we're thinking about gathering them that we need to do this skill, we want to have something to drape the patient. Sometimes they will, because you're passing that tube in the back of their throat, and so they might get a little bit of a gag reflex. And so you want to be having something prepared to cover across their chest. We want to make sure that they have that emesis basins in case they do have a little bit of contents that come up during the procedure. We're going to give them a cup and a straw. While we're putting the tube down, we can go ahead and have them suck on the straw and get some water. That'll help ease the passage of the tube, especially for those that have a really strong gag reflex. We're going to have some tape to be able to tape the tube down to their nose. There are some companies that provide some little already self-created tape that actually has like a Velcro across it, but we're going to go ahead and utilize tape for this since we don't have a lot of the other supply. What I'm going to do with my tape is have the one that'll go across the nose, but then also for the tube, I'm going to take a piece of tape and I'm going to kind of tear it part way down. And what I'm going to do with that is I'll have the piece that's going across the nose, and then I'm going to take what I consider like the pants of it and wrap it around the tube in one direction, and then take the other piece and wrap it in the other direction. That way that we have the tube just kind of hanging loosely, because we don't want that tube pressed up into the nares. I've actually seen a patient that had an NG tube placed for a few weeks and ended up with a notch in their nose because of the pressure of that tube right against the nares. So we want to make sure that the tube is free hanging there. Let's see, what else? We're going to have a stethoscope because we're actually going to be listening for gastric placement. We'll be listening when we inject some air, and then also then we'll pull out some content. We're going to have a pair of clean gloves. This is not a sterile procedure because it's going into the stomach. And then we also need to have a piston syringe. We're going to use this to be able to help and check that placement. We're going to go ahead and we're just going to be using that, make sure that it's got that piston there and not the lower lock. And so we're going to start to get up now that we have some supplies. We can also gather a safety pin to help secure the tube to the gown afterward and use a rubber band to do that. If you're going to have a suction source, you would want to make sure and test that as you're getting everything hooked up. But we're just going to focus on doing the skill of putting the NG tube down. Now, if you're a student on the floor and you've got an order for this, there are things you can do without having the instructor there. You can go check your order, make sure, of course, you've got the right patient, make sure that this is a person that, what type of procedure is being done and what we need it for. And you can go in and start doing some assessment with the patient. One of the things that we want to think about is if we're going to insert this into one of their nares, if there's one that they breathe better out of, like maybe they've had a deviated septum or they've had some type of injury, that what we want to do is kind of just ask them, take their finger against their nose, breathe in, breathe out, then do the opposite side. And if they say, hey, I feel like I breathe better out of the left side, we're going to let them know, hey, great, then we're going to put it down on the right side, because if they, think psychosomatic that, hey, I breathe better on this side, why put a tube there that makes them think that there's, oh, now I'm going to have more trouble breathing. If they've had injury, of course, we may not have the option of putting it on the opposite side. The other thing that we can do before the instructor get there is tell them what we're going to do during the procedure. Let them know that we are going to sit them up. We prefer them being high fowlers, but at least in a semi-fowler, it's a 45-degree angle. And that's simply because if we're putting that tube down there, we start to get that gag reflex, thinking about we don't want them to aspirate those contents. We're going to let them know that, it's not a comfortable thing by any means, but it's not a painful procedure. Let them know that we're going to actually give them instruction that at some point they're going to have a cup of water. We're going to tell them you're going to swallow, 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 and that'll help pass the tube. And usually after the tube gets down, they don't feel like they have that gagging reflex. Let them know that first when we're starting the procedure, we're going to have them tilt their head back. I call it the sniff position, right? Where we can actually kind of see up into their nares. You will be able to feel as it curls into the back of their throat. It's almost, I wouldn't want to say there's resistance necessarily, but you're going to feel there's going to be a little bit of change in that angle. And once you get there, that's when you're going to have your patient put their chin down to their chest. And so you're going to let them know, hey, first I'm going to have you tilt your head back, and then I'm going to let you know, put your chin down to your chest, and I'm going to tell you swallow, swallow, swallow. And the tube should go down pretty smoothly, as long as you push. It's not something where we're just into one little step at a time the idea is to get it down as quick as we can. Let them know that after we get it down, we're going to let them know when they can breathe. If they feel like they're having a lot of trouble breathing, we'll ask them, and if it is really uncomfortable for them, we'll go ahead and pull the tube. There is a possibility, of course, that we could go into the lungs rather than going into the GI, going down the esophagus. And so some of the things that we'll be looking for is if the coughing that normally getting past that gag reflex, if it continues to get worse, if their lips started turning blue, if they have a lot of distress, we'll pull the tube out and we'll try it again. It happens once in a while. So now that we've got the instructions, we've let them know what's going to happen, why it's going to be there, and what that the doctor has ordered it, then you can go gather your supplies. And we had talked about your emesis basin, your cup and straw. That's not something, we'll get a new one, right? And what I like to do with these is actually hand them to the patient. And that's because when I worked on a surgical floor, I found that patients like to help, and I say that very facetiously, and because they want to start pushing, because their inclination is to pull the tube out, but at least if they have something in their hands, they're not able to mess with that tube. What I like to do when I've got the tubing out, and I'm going to go ahead and put my gloves on at this point, so I'm going to start getting ready for my procedure here. And of course, I have checked my orders, washed my hands, ID'd my patient, and explained the procedure. I've got my tape there. This is not going to allow me to keep this on. It'll fall right off, but I'm going to go ahead and drape the patient. And they've got a little cup of water. First of all, when I'm going to take this tube is the way that we're going to measure, because not everybody is, of course, the same size. I worked with a surgeon once, and he said in a case of, you got to get it down, you're in a code, or, got to get them to surgery really fast. For the typical adult, it's 2 in and 2 out for the black markings that are on here. For this skill, what we're going to have you do is you're going to measure from the tip of their nose to the earlobe and down to the xiphoid process. And of course, the xiphoid process is the end of that sternum. So on this mannequin, we're going to pretend this is their earlobe. We're going from the tip of their nose to the earlobe and down to the xiphoid process. And you can see that's this bone right here. So this is where I'm going to put a small piece of tape. I'm just going to take a little piece of this. And I'm going to mark, make it easy so that I can peel it off. Just so that I know that that's how far down I'm going to go. Now, I'll say that when I'm doing checkoffs, this is probably something that students usually miss, and they're getting their tube down, and they forgot to measure, and they're watching because they can actually see the tube passing. Remember, your patients are cut in half, so we have to make sure and measure. Okay, so we've marked our tubing. The other thing I didn't mention in supplies is we also need some lubricant. And of course, we want water soluble because we're going into, the air passageways, and we don't want things that are going to actually build up there. So what I would do is I would just peel this open. I'm not going to because of don't want to get all these supplies done. And I just go ahead and stick the end of this tube in the lubricant, and so that I can just lay that down there. And then the last thing I'm going to do before I actually get ready to start the skill is, because this is just an open connection, right, to so that things could come out, and especially if you have something that is in the stomach that's just sitting there, that now we are going to put a tube down where it can just come out. It's got a pathway to get out. So what I like to do, if we talk about doing, we're going to be able to inject some air, is I go ahead and pull back about 15. Some say 10, and I'm going to go ahead and connect that up because now this is closed off system. So I don't have to worry about, as soon as the tube gets down there, any of those gastric contents coming back up. And we have that ready to go. So when we think about this checkoff, you're getting all your supplies, you're getting your patient. Remember when you mentioned about, because if we're using this for our checkoff, thinking about that with the instructor doesn't have to prompt you and say, and what position are they in? That we want them in a high Fowler's position. If we were using the mannequins on the bed, then you would actually have to raise the bed up for this skill. And remember, 90 degrees is optimal. If they have, really distended stomach, they're very uncomfortable, we can do this with 45 degrees. So we've got our patient sitting up. We've already tested their nares to figure out whether we're going into the left or right side. We've already given instruction to them about that we're going to start off with the head back so that we can actually start the tube, and then we are going to have them put their chin down. So now I've got my patient sitting in that high Fowler's position, one cup that has the water in it with a straw. They have the other hand that's holding the emesis basin. I've got my stethoscope to be able to check and listen for that whoosh sound once we are going to check placement, injecting the air. And of course now I've got my lubricant on my tube. So we're going to go ahead, have them tilt their head back. We can go ahead and use your hand if you wanted to stabilize, but because I don't want to block your guys' vision. And I'm left-handed, so things kind of are backwards for me, right? So we're going to go ahead with their head tilted back. We're going to start there. And like I said, you guys aren't going to get to see this, but you'll actually feel that little bit of hesitation. It shouldn't be anything obstruction. And we're going to go ahead, as soon as we feel that lid is curving in the back of their throat, we're going to say, okay, now put your chin down to your chest, and we're going to tell them swallow, swallow, swallow. Now I'm going to tell you, especially with this 10 French, it's not going to go down nice and easy because this is actually more sticky than a person. The person has all that mucus and everything, and so again, their head's tilted back. We're going to go ahead, we've got it looped up, and we're going to insert in the nasal passageway, and as soon as we start feeling that little bit of curve, that resistance kind of, and we're going to tell them, let's see if I can get this, to swallow, swallow, to put their chin down, and to swallow, swallow, swallow. I'm sorry guys, I'm trying to get this. There we go. Swallow, 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 swallow. And as soon as I get to my tape, we're going to go ahead and say, okay, stop swallowing. Go ahead and just going to breathe a little easier. I'm going to temporarily put a piece of tape here just to kind of hold it in place. I'm going to take my stethoscope and I'm going to place this, of course, where the stomach's located, so down at the end of the xiphoid process, just a little bit to the left. And I'm going to place it there. And what I'm going to do is I'm going to go ahead and give a good little push, poof, and I sure hear that little whoosh in the stomach there. Now, depending on the hospital policy, they may decide to be able to verify placement that they need to have gastric contents, and in that case you can go ahead and pull back. A lot of times after the initial placement's been verified, just aspirating and seeing gastric content is enough to verify that it's in placement. There are some facilities that are not utilizing the injection of air to verify placement, so you do need to be comfortable with what your hospital policy is. So we're going to go ahead at this point. What I'm going to do before I finally take this down is I'm going to crimp this. There is a way that we can actually put a valve on it, a Lopez valve, to where we can turn it so that we don't have to crimp. But I don't want any stomach contents coming out, and I don't want any air coming in as I separate this syringe. So right now I'm going to go ahead and place this so I keep my system closed off. At this point, I'm going to go ahead and secure the nasogastric tube. I'm going to do that by going ahead and placing this across the top of the nose. I'm going to go ahead and take my marking tape off. Remember I talked about, and I'm going to take one of these tapes and I'm going to go around the tube in a spiral, and then I'm just going to fold off the end so that it makes it a little easier if I needed to peel that back. And then this other little pants leg, I'm going to go in the opposite direction. And of course, the advantage of doing this is that it just allows that tube. Remember, the idea is that it's hanging and it's not pressed up against an area, so you want to make sure. And then as my final piece in securing this, what I'm going to do is actually take a piece of tape and go across the top. So we want to make sure the patient's breathing comfortably, that they're now rested. Some of the things we talked about as possible complications is if the tube actually went down to the lungs, the patient continues to cough, was having a lot of distress, we'd go ahead and pull the tube and then we'd put it down again once patients would have a chance to relax. So as far as documentation, is what we want to do is go ahead and put our patient to a place of comfort, clean up all of our supplies, moving everything away. If it needs to be connected to suction, going ahead and following the doctor's orders. The things that I would want to document is the size of the tube, what type of tube, if we connect it to suction, what the settings were, and then of course how the patient tolerated, and also what areas that it was putting down. If we send specimens off to be able to test for gastric contents, we want to make sure that we can actually document aspirated 10 mLs of gastric contents sent to lab for verification placement. And that's how you put an NG tube down.